next speaker, Dr. Mahesh Kumar, who's again from heads Arvind Eye Care Systems from Madurai, and he's going to talk on neuro-ophthalmic manifestations of HIV infection. And I'm really looking forward to hearing from you. You could unmute yourself.
Thank you, madam. Am I audible and are the slides visible?
Yes, yes.
Okay. So good evening, and first I would like to thank the ARC and Dr. Chitra Ramamurthy for having invited me here. And the topic given is neuro-ophthalmic manifestations of HIV infections. So in general, HIV infections may cause 50% of patients may have neurological manifestations. And among all HIV infected individuals, 10 to 15% of the patients may have some degree of neuro-ophthalmic symptoms and signs. And even in asymptomatic individuals, it has been estimated that visual field loss by automated perimetry and coloration loss can occur in up to 40% of the individuals. So the clinical settings with which it may occur are both the afferent system as well as the efferent system. And it can also occur in asymptomatic individuals or in patients with non-visual neurological symptoms. And so it becomes imperative that all HIV patients may need some form of routine ophthalmological or even a neuro-ophthalmological testing to detect undetected visual manifestations. So the modes of manifestations could be due to a direct infection of the HIV, or it could be due to the associated known opportunistic infections, or it could be due to the associated vascular abnormalities caused by the virus itself, or it could be due to the unusual malignancies which are more predominant in HIV infections, or lastly, it can also be due to the drug toxicities. Drug toxicities can be in the form of antiretroviral therapy itself, or it could be due to the associated opportunistic infections like tuberculosis, where ethambutol may be involved. So the clinical symptomatology could be headaches, visual loss, visual field defects, double vision, or just difficulty in reading. Headaches can be a primary headache due to the HIV infection itself, which can be due to enhanced activation of the complements, or it could be enhanced cerebral glutamate levels, or it could be due to secondary causes due to raised intracranial pressure, for example, due to a cerebral venous thrombosis, or it could be due to infiltration of the cavernous sinus. And visual loss could be due to optic neuropathies. Field defect could be due to cerebral involvements. Double vision could be due to extraocular motility involvement due to the cranial nerve palsies. And difficulty in reading could be due to pupillary abnormalities, which may occur because of the virus itself. It could be due to brainstem involvement or other localized infections. So it could be due to other retinal abnormalities. Vision loss can occur. Optic atrophy can be a manifestation of the direct infiltration of the virus itself. So the most common manifestation could be due to HIV optic neuropathy. Again, could be a direct involvement or due to immune reaction by the HIV infected macrophages or due to the opportunistic agents. The manifestations could be optic perineuritis, papillitis, or erythroblast neuritis, or it could be secondary to papilledema due to raised intracranial pressure. It could be the optic neuritis or anterior ischemic optic neuritis, optic neuropathy. And since the virus has got a predilection for the CNS, as it's a neurotropic virus, it can have a direct effect on the retinal ganglion cells and axons. So Nancy Newman and Simmons Lessell have described two cases which were cured only by the antiviral therapy in one case, and one case by corticosteroid therapy, indicating that it could both be the result of the direct infiltration as well as due to an immune reaction. Other opportunistic infections could be due to secondary to viral infection, the most common being a CMV infection, which is one of the leading cause of blindness in AIDS patients. And it could be due to other viral infections like zoster or simplex virus. So among the fungal lesions, Cryptococcus is one of the most common infections which can be due to a direct involvement. Other one being an Aspergillus infection, And Cryptococcus is one of the most common CNS manifestations involvement in AIDS patients. Secondary syphilis can present as optic perineuritis, papillitis, or retrobulbar neuritis. It can occur in the secondary stage of syphilis, and rarely the bilateral involvement can be in the late secondary stages, and antibiotics may need to be instituted. Syphilis also can cause a tertiary, in the neurosyphilis stage, it can also lead to Argyll-Robertson pupils causing light-near dissociation. So tuberculosis is another opportunistic infections which can start with a hematogenous spread. It can be in the choroidal, start as a choroidal tubercles, and later it can spread to the optic nerve. It can be in the form of optic nerve tubercle associated with adjacent choroiditis as well as a neuroretinitis. Pupil involvement can be due to infiltrative lesions of the brainstem, causing light near dissociation and anisocoria. And researchers have found abnormal pupil cycle time, and it has been postulated that the virus can cause an autonomic dysfunction causing pupillary abnormalities. Sympathetic palsies can occur due to lesions of infiltration anywhere along the sympathetic pathway. Argyll-Robertson pupil, as discussed, can occur in neurosyphilis, and it can lead to a small pupils with a light near dissociation. The differential being a large pupil with a light near dissociation as in a dorsal midbrain syndrome, which was a case which was shown by Dr. Daniel Gold in the first presentation. Again, Dr. Dan Gold had shown about abnormal saccadic movements. Abnormal saccades and smooth pursuits can occur in HIV dementia. So long-term HIV infections can lead to dementia, and it can manifest as abnormal saccades and smooth pursuits. The differential diagnosis in a non-HIV infection can be, as shown by Dr. Gold, it can be in a case of a progressive supranuclear palsy, PSPs, and Alzheimer's disease. And cranial nerve palsies also can lead to eye movement abnormalities as well as double visions. Sixth and third nerve palsies are one of the most common due to opportunistic infections. And raised intracranial pressure, as we have seen, can cause a sixth nerve palsy as a false localizing sign, leading to diplopias and
1 minute.
eye movements. Yes, cavernous sinus infiltration can cause third and sixth nerve palsies, which are common manifestations of HIV infections. So, in summary, HIV infection can cause both afferent as well as efferent pathway disorders. It can be due to direct HIV infections, or it can be due to the ubiquitous opportunistic infections, or it could be due to the abnormal malignancies, which are common, most commonly Hodgkin's as well as non-Hodgkin's lymphomas. And these Hodgkin's lymphomas can infiltrate the orbits, leading to a variety of neuroophthalmic manifestations. And a careful history and evaluation and treatment plan can elicit a good management. This thing. Do not forget the drug toxicities. Tenofovir has been shown to cause optic neuropathies, unexplained vision loss. And many of these patients, remember, they can also have tuberculosis and coexistent ethambutol toxicity. Conversely, TB patients should also be asked about a HIV history so that coexistent infection is ruled out. Thank you very much for your kind attention.
Thank you, Dr. Mahesh. That was a very thorough talk. I think paucity of time, we have to move on to our next speaker. There's an amazing talk it was.